Our last panel before our after party, Revenue Cycle Management, featuring Nate Hartman, Michelle Mullany, Scott Leshin, and Elie Levy.
Hi, everyone, and thanks for joining our panel on revenue cycle management. I'm Nate Hartman. I'll be the moderator today. We're going to start with a quick introduction for each panelist, and then we'll move right into a series of questions. We're going to focus on some key topics and frequently discussed areas. I'll try to keep us on track and leave room at the end of the panel for some Q&A. So we want to go ahead with some introductions. Elie, you want to start us off?
Thank you, Nate. Yeah, I am Elie Levy. I'm the founder of Sunwave. Sunwave is an operating platform for treatment. We have a software solution that will address every single business process in the operations of a treatment facility. So from the very initial phone call that a patient or a family member or a friend is making to a treatment facility asking for help, all the way through scheduling that patient into treatment, then doing the treatment, medical, clinical, all of that, and then after that, revenue cycle management, making sure that you can bill, collect, and after that, we have also aftercare, follow-up. I mean, we know the difficulties of this industry. And so I'm very happy to be here and share with you guys what we have to say.
Thanks, Elie. Michelle?
Hi, Michelle Mullany with Prosperity Behavioral Health. We are a revenue cycle management company based out of Philadelphia, but we have a nationwide presence. We have clients all over the country. We primarily serve the substance use and mental health facilities across the country. We also have a significant portion of our business, which is consulting on due diligence for people who are looking to buy or sell a facility. So we'll go in and do an inventory of operations, finance, all of the sort of Q of E stuff to make sure that a facility's, every area of the operations is really ready for selling or scaling. I'm a clinical social worker by education, so I did that for about 20 years, ran lots of different facilities, various sizes and whatnot, and then have been with Prosperity now for just over a year, and I'm joined by my colleagues here, the co-founders, Aaron and Greg, and some of our team. So if you have any questions, feel free to reach out.
Thanks, Michelle. Scott?
Thank you. Scott Leshin, President and founder of SJ Health Insurance Advocates. We're a full-service behavioral health revenue cycle management company in New Jersey. We work with a little bit over 100 facilities nationwide, VOBs, authorizations, claim adjudication, the full gamut.
Awesome. Thank you for the intros. Scott, why don't we start there? Getting authorizations in general, and specifically authorizations appropriate for the patient in question has always been a pain point in this industry. Can you talk to us about some of the trends you're seeing in coverage and authorizations?
Sure. Thank you. So the Affordable Care Act mandated that policies cover mental health and substance abuse, and the ability to secure authorizations, certainly has been continues to be a challenge. So one of the things that we see is treatment facilities must educate their staff to chart for medical necessity from a deficit base, meaning they should keep in mind is what is preventing a patient from discharging or stepping down to a lower level of care, because that's going to continue to get authorizations. I also recommend whether you do the utilization review piece in-house or outsource, that you use licensed clinicians to do that, because we find that there is a certain level of professional courtesy afforded between an LCSW working to get the authorizations and, let's say, the LCSW at Aetna or Blue Cross to give you those authorizations. That definitely helps.
Awesome. Moving along, Elie. Excuse me. Two of the common challenges that I think providers face are rejections from the clearinghouse and denials from payers. Why do you think it's so challenging to get billing and claim submissions correct?
Okay, that's a good question. I will start by saying that I think that's the nature of that question is like at the crucial point of how we thought about designing the Sunwave RCM module in the first place. To think about the claims generation in isolation is a mistake, right? You cannot just generate claims with anything for that. The whole process really starts early on with admissions. Right? You need to have a very strong process in admissions to capture properly the information of the patient, then do the verification of benefits, and like Scott was saying just a moment ago, during the authorizations, utilization review, UR, all the same thing. Very challenging processes. If all of those are not happening properly, you will not get the right information in the first place. You will get claim denials, rejections. Then we move on into, let's say that all of that is figured out and we have all of that information together. We need to go into what you were actually asking me, generating these claims and submitting them to insurance companies to get payment. Easier said than done, right? So we have these billers that, no disrespect to anyone, they are super knowledgeable workers, extremely smart, but they have their own secret sauce, right? They have their magic on how to grab all of that information and put it together into a claim form. Actually, there are two different types of claim forms. We have the UB04, the CMS 1500. This individual needs to be able to pick based on what is the insurance company, what is the plan of the patient, what is the service that was rendered, all of that information, collect it together and decide how to configure this claim form. Each claim form, as most of you will know, they have over 100 fields, more than 100 fields. We have over 1,000 insurance companies in the US. Depending on all of the combination of that, the fields that we need to put in this claim form can be different, right? Not all the time are different, but there are variances here and there of what each insurance plan will require you to put in these claim forms. So it doesn't matter how good of a magician this biller is, we are all human, right? Even though we are really, really smart, we all make mistakes. Right? It's unavoidable, it's human nature. So that's where I was analyzing the problem when we were starting to build the module, and I thought this is a perfect scenario to create something that we call in technology a rules engine. A rules engine is simply an algorithm that you can configure with different parameters, and you can capture knowledge to execute the same tasks again and again. And the way that Sunwave is built is that all of the information is in the same database. It's one database where all of the information from admissions, clinical, everything is in there. And we are capable of using these business rules that the magicians or the guys that have the secret sauce, they can configure their own rules. And the system will, every time that we have the same combination of factors, the claim is always going to be generated the same way. And in that way, we minimize the number of rejections and denials. But thinking more about it, we are all thinking about rejections and denials, which are the problems that we see every day. There is an even worse problem. What about billing less services than what you provided or more services than what you provided? That's a bigger problem. To me, especially billing less is a bigger problem because nobody's going to come back to you and say to you, hey, you billed less than what you actually did, right? So that's all of that, you know, not having a system that gives you the visibility to what is really going on is extremely, extremely difficult. So I hope that I answered.
Yeah, no, thank you. As a follow-up to that, I know one of your areas of specialty is artificial intelligence, AI. You and I went deep into the weeds yesterday talking about AI, but I wonder if you can share some of your thoughts on how you see AI being used in this industry, maybe specifically revenue cycle management as well.
Okay, that's an interesting question that I think that we are all concerned about AI these days. We hear it in the news every day. And I promise you, I will not go into the politics of that right now. I will stay into the very practical, technical for today, right? Or the type of things that we are actually working on. And I will try to focus it mostly on the RCM, which is the topic of this forum. So I will start by thinking about collections, which is one of the biggest challenges, right? Collections is extremely difficult, especially when we are in an out-of-network. We are always trying to catch up and trying to find out where our money is. And we have limited resources. We need to make sure that we organize our teams properly so that we can go after and be able to collect as much as possible. So one of the things that we are doing is looking into historical patterns using the AI algorithms that are so popular now. And I will talk a little more into the details of that if it's something that you guys are interested in. But we can analyze these 100+ fields that I was talking about in the claims, look at claims that are similar to each other, and understand, like the AI itself is understanding, how quickly should we get paid for this type of configuration in that claim form. And we have this claim form that all of the other claims that belong to that same classification, categorical classification, to use a more technical term, they are being paid in 2 to 3 weeks. But there is this claim in here that has been standing for 5 weeks. So it's a lot smarter to go after that specific claim instead of just doing what we are doing today, which is just different buckets in our aging report. We know that this one is 30 days old, 30 to 60, 60 to 90, and so on. We have a smarter way to get insights into what claims should be going after, right? So that's an exercise that we are working on, that we are getting pretty interesting results, and I think that there is something in there for us to explore further. So going a little deeper into the AI stuff, I'm sure that all of you have heard of ChatGPT. Maybe some of you or most of you have played with it. Some of you are scared of what does that do. This is a technology that has been building blocks over the years. And one of the biggest challenges that we have to adapt that type of model into our industry is privacy, HIPAA, right? It's something extremely, extremely important. And the other thing is that ChatGPT and all of those algorithms that the big technology vendors are pushing for are generalists, right? They are very good at understanding a very broad range of knowledge. So what we are doing is we are grabbing the base of those models that are built by universities and they are put in the open. So we have right now 2 experiments that we are running. One is with a model that has 7 billion parameters. It's just a number. The other one has 16 billion parameters. As a matter of comparison, GPT, I think that it was GPT-2, which is the first one that was really, really popular from OpenAI, they have 175 billion parameters, right? It's a completely different size. But what we are trying to do is grabbing these models of 6 or 15 billions, and we are actually fine-tuning the training of those models specifically for our industry. We have over 100 million medical records in our system, right? Individual notes that we have captured over the years by all of the providers in the industry that have been. So we are using that, cleaning the PHI out of those, and we are training our own model to actually be able to see what type of insights we can get. So a specific application that we have seen a lot of value will be on the insurance authorizations, which is a very challenging specific topic. And we are able to, given what the insurance company is asking the agent, suggesting what area of the medical record of the patient the agent needs to look into to be able to provide the right answer to the insurance company. We are in the early stages of that, but we are getting very promising results on that specific case. Another area where we are trying to apply this is in the claims generations that I was talking a moment ago. I was talking about this sorcerer, or the guy that has the secret sauce for creating these claims. So we are trying to see if we can generate AI to actually be able to predict what type of changes or what type of rules are configuring correctly in the system so that we minimize those rejections and denials. And if I was to move into another topic, another area where we believe that we can use this technology is helping treatment. So maybe you are thinking, I am going to put a patient to talk to an AI to give treatment. I will never do that, okay? Maybe I should not say I never because I really don't know. Never say never. But the way that we are thinking about it is having the AI agent as an earpiece on the therapist. And the AI agent is going to be listening to the conversation. It's aware of all of the medical history of the patient that is in the therapy session. And the AI can actually pinpoint to the therapist areas where the therapist should be focusing on. Right, so we know about the clinical proven therapist, the styles of therapy. So if the therapist is moving away from what the therapist should be doing, we can correct giving feedback to the therapist. I want to mention that one of the biggest challenges that we are having, that we are experiencing in this, is a kind of a funny technical term that we, the technologists, are using, that in this room, it has a completely different meaning. It's the term hallucinations. Am I pronouncing it right?
Yeah, hallucinations.
Yeah, hallucinations. So in the case of an AI, a hallucination is something very different from mental health and behavioral health. In AI and the technology geeks, we refer to a hallucination as the AI is giving you something that doesn't make any sense, right? And that these models are really, really complex. These are mathematical models. If anyone is interested in to go in a little deeper, I am more than happy to go deeper and explain how this whole thing works. But essentially what is happening is that I was telling Nate yesterday, we get a 30 digits number, and we put it to do an addition of that number with another 30 digits number. And we have not trained the AI into knowing how to do that calculation. But to our surprise, it actually knows how to do it. And it gives you the exact right answer, which is unbelievable, right? Now, the challenge is that if we put a 30 digits number and we put it plus a 10-digit number, it just gives you a number that doesn't make any sense, right? So that's what is a hallucination, or what we call a hallucination. I am having difficulty. My British accent doesn't help me with those terms. But we need to figure out a way to minimize those and make sure that it's actually giving the right answers to the people so that they can actually complete their job. And I think that that's probably the biggest challenge on that.
Super cool. Thank you. Thank you, Elie. Moving on, Michelle, one of the challenges for providers is that they don't know what they can't see. Can you talk a little bit about the importance of reporting and why some groups get it right and others don't?
Yeah, sure. First of all, I'm really impressed with the attendance here. I thought last one of the day we would not be.
Right.
So I thank you for coming. This is great. And if I had to pay you to come here, don't mention it to the others. So reporting, just like any other industry, reporting in behavioral health and in revenue cycle management can be as simple or as complicated as you make it. Ultimately, you want to make sure that you have a billing company or a revenue cycle management company who is high quality, attentive, thinking outside of the box, really looking at the trends and the claims to ensure that they are making corrective action if they see something or if they notice it. So the ability to spot a trend amongst hundreds and thousands of bills is essential. Again, and in addition to that, having somebody on your team at the facility who's kind of looking at that aspect and looking at the billing and making sure that things are going out correctly from the facility to the payer, that's correct the first time, is essential. So there is some level of responsibility that falls on the treatment facility to make sure that those claims go out correctly. That said, when you're looking at what metrics to evaluate and how important reporting is, if you don't have those two elements, then your reporting is not that great anyway. So those building blocks are essential. When you sort of add on to that, you want to look at the not having too much data coming at you. So if you are running a facility, clinicians are always doing 7 or 8 jobs at a time. We want to make sure that the reporting that people get at the facilities is streamlined, it's accurate, it's timely, and it is really the metrics that matter, the things that make sense. KPIs and metrics are only good if they're actionable. So in reporting, you want to make sure that fancy dashboards are great and they're pretty and they have lots of colors, but essentially, if you can't go in at any level of the organization, whether it's the biller, whether it's the CFO, whether it's somebody else, and extract what it is you need to operationalize it, then you just have fancy spreadsheets, which is cool and very impressive. So when you're looking at reporting, it's essential that you figure out what are the metrics that you want to measure, what's important at every level of the organization, and that you can have immediate change to operationalize those and make corrective action. In the treatment space, we're looking at a market that is consolidating rapidly. Rates since about 2015, when there were significant rate changes and the payers started to catch on to out-of-network billing, et cetera, the amount of, the reimbursements have sort of stabilized. And so inflation's still happening. The cost of, attracting good talent has increased. All of the same challenges we've heard over the past 2 days still exist, yet the reimbursement has not changed in many years. So we want to make sure that, as consolidation happens and it costs more to operate a facility, that those metrics and the reporting allow an operator to make immediate changes. It's really critical, especially in this economic environment. I would say also other kind of things to look for when you're in reporting is how intuitive is it? So one of the biggest debates in revenue cycle management is, do you bill gross charges or do you bill out your contracted rate? Most people are still billing out gross charges. When you bill out gross charges, though, that's just a number that somebody made up and put into a system to go out to the billing company. So I could say it's, I could put $10,000 in there, but that's not meaningful. And so as operators, what you want is something that comes back that is meaningful. What was the gross charge that I sent out? But really what's important is how much of that am I going to get paid? So we have, at Prosperity, what we have is dashboards with and algorithms built in so that regardless of what the number is of the gross charged amount, we can look in at that dashboard at any given time, and based on historical payments, et cetera, we can predict what the payment will be for that specific service, sort of at the dashboard at any time. So having KPIs that matter, that are actionable, having simple metrics to look at that make sense to the entire organization, and the ability for any person to come into reporting and have it make sense. You don't want just reports that work for the CFO, and you don't want reports that just work for the biller. It's just, you want something that is comprehensive and simple enough, but actionable.
Yeah. Thank you, Michelle. Scott, can you build on what Michelle was just talking about and walk us through some of the key metrics that we should be measuring and why?
Sure, thank you. And I agree with 100% with Michelle as far as billing out a gross and then what you're collecting, because I could bill out $10,000 for an IOP session and get $250. My coverage ratio looks like, I won't say it on the microphone, but it looks. Thank you. But so that's something that I just think I get asked this all the time. How much can you get covered on a bill? Well, that's really in my opinion, a question that really shouldn't be answered. There's a lot more to it. But what a billing company, or if you do it in-house, certain things you can control: days authorized and days for claims to adjudicate, to varying degrees. So there's obviously a lot of KPIs out there, but two things that if I, given the how much time we have, I'm going to want to be looking at days authorized per payer per level of care. And then I'm also going to be looking at days for adjudication per payer per level of care. And in-network, certainly it has to be in line with your contract. Any deviation from your contract should immediately be brought to the contracting department. And for out-of-network, what we see is about 60 to 70% of claims adjudicate within 30 days, and there's always going to be some issues thereafter. These two metrics, authorizations and days for adjudicate, help drive, obviously, revenue, but also help drive admissions decisions. So if you're in a residential treatment facility with 10 beds, you have one bed open, one guy is on the phone with Blue Cross, the other guy's on the phone with Aetna. Knowing these two things can help determine which patient you should take in. And also adding on that, data's all great, but it has to be actionable and intelligible.
Yeah.
If I could just add on to
Yeah,
that quickly,
please.
I agree 100% with what Scott said. This kind of goes back to what sort of reporting do you want. Somebody who's doing the billing, they may want to know what were the collections in the last 7 days, but the CFO doesn't really care about that. The CFO cares about what has my cash been for the last year. And so again, when you're looking at reporting, don't necessarily be seduced by tons of information. Again, that's just another way of saying we really want accurate and actionable information.
Yeah, and if I could go off script just a little bit, you talked about authorizations and days to adjudicate, right, as controllable things. As a provider, what if I came to you and said, well, but no, I can't control those things. Those are the payer's going to authorize what they authorize, and they're going to adjudicate the claims as quickly as they're going to adjudicate the claims.
Sure. So I would, I would counter with going back to what I originally discussed. Having a facility that's charting on a deficit base will help get you more days authorized. Having a good trained staff of clinicians doing the utilization review will help get more days authorized. You're right in that, look, an insurance company, we're their enemy, and they're our enemy, and we're working against each other. But that is something that you could potentially drive more days, doing those two things. And with days to adjudicate, certainly insurance companies love to deny claims, love to tell you that, we're short-staffed and sorry, we'll talk in 90 days. But is your billing department, again, in-source or outsource, following up, not waiting 30 days to call back? Are they following up in a few days to make sure things are actually moving along? Are they escalating past just, the 1-800 number to supervisors? Are they filing complaints with state regulators or with HR departments if they're self-funded plans? So those things are absolutely items that a billing company or in-house billing department can control.
Awesome.
Yeah, I would like to add to that. As we are talking about reporting, I think that we need to look at the holistic operations of the treatment facility, right? Like I was saying before, everything starts from the initial interaction with the patient. So being able to report across the board, across all of the things that are happening in treatment is extremely important to maximize revenue cycle and to maximize the outcomes of treatment, right, together. So I have a statement that I use that I talk is the string of treatment, right? Is to be able to see at every single touch point that we as a treatment provider do with a patient. How many phone calls did we do for admitting the patient and so on? How many phone calls did we do to call the insurance provider to get authorizations? So it's every single touch point. I'll give an example of something that I believe that is super valuable. To be able to understand how is our reimbursement rate by referral source or by admissions representative, right? These are incredibly important metrics that, depending on what is your infrastructure in terms of data and how the data is organized, it can be extremely, extremely difficult. And in the case of Sunwave, you have, because everything is stored in one database, right? Our platform is a real platform. It's not different solutions that were built over time that were integrated, that if you talk with me after this, I can explain to you, but that will never work properly. When you have all of the data in just one database, you are going to be able to pick what are the data points that you want to report on, and you can actually get insightful information on what is working in treatment and what is not. And you can discover a lot of very interesting things. We have a client of ours that I remember vividly. He called me, the CEO of this organization. They had like 4 different treatment facilities in Florida. And they have been running our platform for 2 weeks. And he calls me and he starts screaming at me that our system doesn't work. And I was like, hold on one second. Why do you say that? And he said, every single claim that we have for AmeriHealth is getting rejected. We are not getting paid in one claim from AmeriHealth. It's our cash flow. It's killing us. So I said, okay, let's get together. We did a Zoom meeting, sharing the screens and looking at the reporting. And thanks to the ability of being able to drag and drop data elements to try to understand what was going on, we discovered that the way that they were set up with AmeriHealth was not working properly. It was not set up properly. And this came from the prior system that they were using before. And we found that they had more than $400,000 that they didn't bill in the last year. And so the ability to be able to look at the holistic picture of everything that is happening is extremely, extremely important. Right?
Yeah.
And that's very difficult to achieve.
Yeah. Thank you. Michelle, can you kind of tie this all together? What are some of the improvement opportunities in the revenue cycle management, the RCM function in this industry?
Yeah, certainly. To my earlier point, getting reporting that is just in time and makes sense. Again, everybody has dashboards and data right now. Sometimes it's garbage in, garbage out. Just make sure that you're a good consumer of what you need to run your operations, and then let good, smart people kind of help you with that. We are seeing lots more integrations with the payers through various types of technology. Obviously, talking about AI, I mean, who would have thought even 3 years ago that we'd be having this conversation? But the payers are, at the end of the day, the payers are still the payers, and they're still implementing their business model, which is to deny claims and make it difficult. So we have to be very mindful. You know, revenue cycle management isn't complex. It's not rocket science, but we make it a lot harder than it should be. So what we see is when people come into this space, they think, well, I want to do it myself. And sometimes that's the right answer. But look for a technology solution that actually works for the level of care that you have, the type of services you're providing, and then the type of services you want to grow into. Having a solution for your business today is great, but if it's not scalable, it's going to be obsolete. It's going to sit on the shelf, and that'll be that. I think what we see is it's great to have a process. Having scalable, repeatable processes are very difficult to create in revenue cycle management. So once you have the right people in place, once you have the right processes, it's great, and then you have to look at what technology is going to benefit you as a company and your specific business. I think I would say, sort of in closing, that a lot of these things are easy to do. It's hard to do them well, and it's hard to do them over and over again, kind of like I just said. But when you're looking at a problem in revenue cycle management, do not oversimplify it. Do not think that you can do this without at least consultation or finding the right billing partner. There are a lot of reputable billing companies out there. And there are a lot of companies who have smaller shops and don't necessarily have the bandwidth that some of the more quality billers have. So I would just say pay attention to that, and make sure that the reporting is and the metrics that they're giving you are what you need when you need them to make changes to your operation.
Awesome. Thank you. We do have a little bit of time left for Q&A. If you guys are willing to take some questions, we can open it up to the audience to ask some questions.
Even though it feels like we're in a CIA questioning room.
Hey guys, can y'all talk about the importance of clinical notes and their impact on receivables?
Sure.
Yeah. So
Go ahead.
Can I start? Yeah. So obviously, unfortunately, right, in healthcare in general, and specifically in this industry, we have been victims of a lot of fraud, right? I was sort of talking at the beginning about billing services that you didn't render, or missing services that you actually render and you didn't bill. So the insurance companies are really difficult nowadays in terms of accepting that you did a treatment or you didn't. And for that reason, you are going to get a lot of denials in asking you to prove medical necessity. Right? So that's another one of the areas that we are exploring using AI for that. And we are using that differently in different dimensions of medical necessity. One of them is trying to identify if there is a therapist that is doing copy-paste. It's something that we have seen that some therapists are doing a group and they just are so tired after doing the group session in the evening. They just need to get the groups done and they go the easy path of copy-pasting the bulk of the note. And then the treatment provider, the facility itself, can get in trouble if the insurance company was to conduct an audit or was going to ask to prove medical necessity, and you send the cookie cutter notes. It's extremely important that you have really clean notes that really reflect what treatment was provided. Now that's from the perspective of RCM. I believe that independent of RCM, in order for us to be able to do what we are here really to do, right? We have a mission here, which is that we recognize that there is a terrible disease that we are all trying to make better. We still don't have an answer on how to cure it. But in order for us to be able to get better, we need to have really good notes. It's the only way that we can really understand what is going on. It's the only way that we can really drive for better outcomes and that we can drive for better care. So I believe that clinical notes are extremely, extremely important.
You know, Scott mentioned this earlier, having clinical folks doing your utilization review. This is exactly why, because a clinician can really think outside of the box and think broadly. So I'll let Scott kind of speak to, you know, how his teams are doing that. But ultimately, it comes down to, are you giving people, we can over-template anybody. So we want to make sure that the teams that we have are in the notes, understanding what the various clinical implications are, but also what's the plan B. So if I can't get authorized for a certain level of care, a certain level of days based on someone's usage, well, how can I pivot quickly? So having people with critical thinking skills is just as important and often overlooked for the sake of technology and templates. You know, do I have an ASAM template that's going to get me authorized? Well, perhaps, but really making sure that the teams in-house are documenting in a timely manner. Anybody who's managed a social worker, I am a social worker, knows that we hate to document, we hate to type notes. So you have to have teams that understand if that note doesn't go in and if it's not accurate the first time, then that claim is now not a clean claim and you have started the delay in getting paid for that claim. So having an understanding of the business with all of the clinical teams is essential. They need to see behind the curtain to understand what's happening. Having licensed folks, and then not over-relying on technology to do the job of documentation. You really do need critical thinking skills, and you have to have, like I said, a plan B.
And I'll just add that audits happen, and they're always going to happen, and Optum's digging around regularly. And they're just looking for one reason, one level of care mismatch between what the claim was filed at and the note itself, just to latch on. So that is something that absolutely has to be very, very closely monitored.
Yeah. Thank you. Other questions?
We have 2 minutes.
2 minutes. Don't all raise your hands at once.
Is anybody in the audience thinking of getting into this business and just has a question that they feel like, gosh, this is it? It's the dumb question that 10 other people are thinking. Is there something that's just on your mind that seems like a basic question that you feel comfortable asking? Yes.
Sometimes it has a back office SNF, outsource as opposed to yourself.
So I think the question is, if you have a back office billing company for a SNF or another subset of healthcare, why outsource it to a billing company? Yeah, I'll let my colleagues also give this a stab, but essentially, kind of what I mentioned, it's, so first of all, behavioral health billing is very nuanced. It is, the slightest detail can make a difference in your length of stay. It can make a difference in the authorization, the initial authorization. We used to have competitions when I worked in an emergency room about who could get the most days out of United Healthcare, because they were always just authorizing 2 days for acute care. So we used to have a competition because, and it comes down to who has the most sort of nuanced way of getting things approved. So it is nuanced. and the people who do it over and over again do it very well. That's your people. And then the processes, it's different times to follow up with a claim, to make sure that you're looking at your AR to see where that claim is in the life cycle. And I would say having the technology and scaling that and being able to scale those processes is where outsourcing that's the sweet spot of outsourcing. It's great if you want to have 1 or 2 billers in-house, but as soon as somebody goes out on FMLA, Mary Jane, who's your best, probably bad use of a name here, but Mary Sue, who is your star biller and is getting claims, and she runs the auth team. She has a grandbaby, and now she's out for 3 weeks, and everyone's like, well, what are we going to do while Mary Sue is gone? This happens every day in facilities, and believe it or not. So outsourcing really has a backup plan. You can, keep your staffing model. But the most critical thing is that you as an operator can focus on what you want to do, which is managing your business, operating it, and scaling it. And I think we were just talking about, I just looked at a year-over-year report of our clients at Prosperity, and a few of our clients have grown by 40% this year. And the correlation that we determined is the people who grew by 40% are the ones who let us do the billing, and they're not calling and emailing us over every dollar 20 times a week. They are letting us do our thing. They're giving us the freedom and the flexibility to kind of bill, and what they're able to do is scale and grow their business. And ultimately, that's what we want to support you doing.
And I would add to that. Obviously, we're all biased because we're outsourced revenue cycle management companies. But if you're just getting into the space, you have so many other things that you really need to worry about. And while it's different, there's certainly partnering with somebody that can take that burden off your plate for a certain period of time until when or if you're ever ready to come in. And you might find yourself outsourcing skilled nursing by the time a good pillar is done with you.
Yeah. I'll share a story quickly. We're out of time, sorry, but I ran a large healthcare facility, behavioral health service line for many years, and I fought tooth and nail to insource our revenue cycle, and I won. We set up shop, we had all these billers, hundreds of claims. I must have had 10 people on the denials team. We set up a front end team to make sure clean claims went out. 3 years later, they were looking at outsourcing. I left the organization, but it's one of those things, if you're not constantly, vigilantly paying attention, then you can't manage it the way you need to manage it.
Thank you, everyone, for joining us. Thank you,
Thank you.
panelists, for sharing. And they'll be around for more questions afterwards, so thanks, y'all.